I'm Minwanamad, Nindinjnakaz, Kitaganzibi Nindonjaba, which means Minwanamad means pleasant breeze in English. Algonquin? Does that make sense? In Algonquin? In English. Minwanamad means pleasant breeze in English. It's a translation from Algonquin. I'm from Kitaganzibi. So I'm Sarah Funnell. I'm a First Nations family physician, public health specialist, and I do some research. And I'm the Associate Dean and Chair of Indigenous Health here at the Faculty of Health Sciences at Queen's. And I am a band member at Kitaganzibi First Nation. That's an Algonquin community in Quebec, which is now known as Quebec. Yeah, I'm also a wife, a mother of 3 daughters. I have 2 dogs and 2 cats.
Sego Sebugwego, Jamaica Yungats Dino Cass Danaxwazere, and I'm Ganyanke Haga from Gandege. My name is Jamaica Cass. I am Mohawk from Tyendinaga. I am a family physician and I work in my home community of Gandege or Tyendinaga, and I am a member of the Mohawks of the Bay of Quinte. At Queen's, I serve as the Director of Indigenous Health within the Department of Family Medicine. I'm also the director of the Queen's Winnebago Health Education Program, which is a partnership between Queen's University Faculty of Health Sciences and the Winnebago Health Authority and the MasterCard Foundation.
So my name is, the eagle comes sounding in. So my name is Nathan Cheechoo. My home is Moose Factory Island. That is located in James Bay, Ontario. I belong to Moose Cree First Nation. I am a Indigenous Recruitment Coordinator, Student Advisor, and team member with the Waha Project. I have a background in paramedicine, firefighting, so a lot of frontline first response. And I have 8 children, 1 dog, a fish, wife, and many brothers and sisters.
Let's do it.
What excites you about your work at Queen's right now?
I think it's more or less the blank canvas of creating a broader space, especially with more digital interface and that innovation within that area for isolated communities like mine in James Bay, Ontario, Northwestern Ontario, even up towards NWT, like just Northern Canada in general. I think oftentimes there's not enough emphasis on that, and if you've all been down rabbit holes in websites, it can get really daunting. So bringing more of a simplistic method of creating that content and bringing that content information to the audience in a way that is friendly to the network and infrastructure of these isolated areas. And can load quick and give them information to make informed decisions in the future.
I'm excited to work with both of you, Nathan and Jamaica. I love working with others. You know, in the pandemic, I worked with others, but I was at home a lot. I worked for public health, and so I really missed being with people and in person. And I think the other great thing about the work that we do is that you know, with the work that we've done nationally, the National Circle for Indigenous Medical Education, or the various colleges, College of Family Physicians of Canada, or the Royal College of Physicians and Surgeons of Canada, now when we work as a team like this, we can bring what we've done nationally with our colleagues across the nation, we can bring it to like the students that we see every day, or our faculty or other leaders. So I think that's exciting, like bringing all that national work to life, like that knowledge that we've collated across our medical matriarchy and bringing it to students so that we can work collectively to make Queen's a place of belonging for Indigenous learners.
I think it's really powerful that we have plural Indigenous leadership in the Faculty of Health Sciences, because where a lot of the work that we traditionally do in colonial institutions is very siloed, I think we have a very collaborative group, and I think that's certainly to the benefit of our learners, absolutely. I am thrilled to work with the pair of you on what we affectionately call the WAHA project, or the Winnebago Health Education Partnership. And that's particularly meaningful to me because I think, the Truth and Reconciliation Commission calls to action came out 10 years ago now, and astonishingly little has been done to meet those calls. And I really see this project as the most comprehensive attempt at addressing TRC 23, which is to increase Indigenous representation in the healthcare field, but more importantly, to retain Indigenous healthcare workers in community. Yeah. And so if we can train nurses and physiotherapists and paramedics and physicians in community, not only are we removing that barrier of these folks needing to leave community to get their education, but then we hope that they'll stay on and they'll work in community and maybe be our faculty one day. Yeah. And I think that's never been done before, and I think it's my hope that not only can we do that at Queen's, but then that serves as a model that maybe other universities will pick up, and really, we, just like you said, we won't leave our rural and remote communities behind.
Yeah, and the thing too, when the students are doctors and nurses and everyone else in between, is that our community members will no longer have to come to places like Kingston for medical appointments and be away from family and have to upend their lives because there's no dialysis units back home, or there's no cancer treatment facilities or anything like that. And especially for the surrounding communities, maybe to the west of Ontario, northwestern Ontario, maybe they have the potential to come to our hospital once it's built and everything's established. So that's another thing that excites me for the future, and I passionately wear the strength of my people on my sleeve when it comes to progressing everything forward.
So Jamaica and I were at the Indigenous Physicians Association of Canada annual meeting just last week in Saskatoon, and it was so heartwarming to see the medical learners. They were so excited to be there. And, there were medical learners there that Jamaica and I had mentored and been a part of their journey. And to see them be medical students was amazing. And so I love seeing that. And that gathering had the most number of Indigenous medical learners and physicians I'd ever seen.
It was, so I'm on the board of the Indigenous Physicians Association of Canada, and we had 220 people attend. Most of those were Indigenous medical students, medical residents, or physicians, and that's the biggest gathering we've ever had. And truly, it's just the best feeling to know that every year that gathering is bigger and bigger, because not only do we have more and more Indigenous learners, but more and more support from our communities and institutions to attend the gathering. It's really powerful.
And while we were there, a staff at the University of Saskatchewan said, "I hear Queen's is doing great things." And that felt really good. And the other thing about gathering us all together is you can see the importance of roles like Nathan plays in recruiting and supporting students once they're here to make it feel like home. And so I hope you know how important you are in supporting students.
Yes. I get emails at random times of the year saying thank you. So I'm really, and that's sometimes as a recruiter when you're on the front line or on the road or just in emails or development or content curating, things like that, it gets pretty mundane at times because it's when you're looking at a screen for hours on end and it feels like you're getting nowhere. And then you realize the people you've helped along the way, not all of them, but those few that come back in full circle say, "Hey, I'm starting at Queen's in the fall. You really helped me with my decision," or "You helped me get through. You've led me to the right people, and now I'm looking forward to meeting you, next year." So I've gotten a few of those over the last few years, and that's been really it's been really helpful, and I'm very proud that even if it's a few of us coming through education, a few is better than none.
I hope and expect that our faculty is going to be flooded with Indigenous students with the way things are going. The other universities are like, hey, what's happening at Queen's, you know? We're setting the bar really high, I hope. I know that's our goals. Okay, so my question to you. Since we are going to flood the Faculty of Health Sciences and nursing, OT, PT, medicine, and undergraduate health sciences, as well as graduate studies, public health sciences, with Indigenous learners. Just imagine there's Indigenous learners everywhere. How do you two think we can build supportive spaces for Indigenous students, staff, and faculty?
That's a good question. I was talking about this today with a friend of mine, and I think it's more or less understanding the lived experience that they bring to the table, as youthful as they are. You know, we have students that come from far, close even, and they all bring something that can lend perspective to those that are in the administrative portions of our faculty. Oftentimes we say, this is what we do for you, however, we never listen or not often listen to them and saying, well, this is what we need. Oftentimes the adults were saying, we're doing this for the youth, yet we're not listening to the youth, right? And as much as their students and their young adults are coming into their own pathway, whether it's first year to fourth year or graduate, whatever path it may be, I think there's always some sort of perspective that we can learn from our young people when it comes to how they want to be treated, how safe they want to feel, and that can guide us through as adults for the next cohort and the cohort after, right? It also has some matter to do with capacity. Do we have the capacity of employees, of people that can support our high influx of students in ways that we're also not burnt out?
I think I would say for students, first and foremost, it is essential that they come into a space free of discrimination. I think we need to ensure that we have adequate staff, and absolutely the staff need to be adequately resourced. I think we need to appreciate that there's a disproportionate number of Indigenous students who come in as mature students. So many of them have things like families and previous careers, and therefore they're going to have unique needs that other students might not have, and that needs to be considered when we're thinking about student supports. And I think I would also say it's important to remember that they might need unique support, so cultural support as well as academic support. For staff, I think Nathan makes a really good point that it's important, I guess, just first of all, that we have enough of them and that they're appropriately resourced, and that we're really mindful about how we take advantage of their expertise, because of course we worry about the minority tax and burnout with Indigenous staff, so we want to be mindful that we're not asking them to go above and beyond their job requirements, because we want to retain them and they're really important. So that's crucial. And I would say for faculty, we need to make it attractive to come here, to be an Indigenous physician or faculty in another department and work for QHS. And I think there's lots of different ways we can do that. For example, you know, when looking at promotions criteria, make sure that things like lived experience and community efforts are recognized and are seen as just as valuable as ginormous grants and prestigious publications and speaking invitations.
I don't have much else to add to your both of your brilliant comments. I'd say, like, it takes a team, right? Like, so there's our team here at the faculty. So, for example, you know, we've all been involved in Mishkiki Mikan, which is a program, like, very grassrootsy, I'd say, built from a small grant that was designed to support Indigenous students that wanted to apply to medicine. So I think it started with a couple of universities, and then we joined. And I think when we collaborate that way, we can help more people achieve their medical dream if that's what they want. I don't know, maybe we can spearhead certain, like, we could replicate that for other health professions, perhaps, if it's needed.
I think adding to that is also bringing community within the institution, within the limestone of the university, and really involving our elders, not just locally here in the region, but also in areas like James Bay, and bringing others from, Wikwemikong, even further west, and bringing in that, because it's the days of pan-indigenizing us as a group is over. There's distinctions between Kliganzibi, Tanzanaga, Moose Factory, and we have our cultural distinctions, and sometimes even the Inuit and the Métis, we sometimes we long for home when we're not home, and how do we get that? How do we satiate that for ourselves, and also students that are from BC, maybe like Haida Gwaii, or out in Maliseet territory and on the East Coast. So what can we do as providers for the youth and students here to ensure that homesickness is met with something positive, and not you'll be okay, but including our community leaders, again, close and far, to come down and share what the knowledge they have, whether it's feasts, whether it's basket making, or tamarack goose making, or Inuit song and dance, or even Inuit games, things like that. I think it would be bringing it down to, again, grassroots, wholesome, really bring the community. And I think that's a big thing, is why community is so important. Not community engagement, but inclusion of community leaders and elders, and not necessarily chiefs and councils, but those healers and those people that we've leaned on and seen others lean on within our communities over the years. What do you feel are some of the most important or pressing issues in Indigenous health and health research right now?
Right now.
Right now,
right
in this
now,
moment.
Right in this moment, in
Big
this
question.
room. The most pressing issue in Indigenous health and Indigenous health research right now is the lack of self-determination. And from which that everything else flows, right? So it's, as we talk about working within a colonial institution, an academic institution, we also work in a colonial health system in general, in the most part, although you may have a different perspective on that working in your community. And the research system is also colonial. And so the most pressing issue, and I think where I have the most difficulty, is being tasked to transform that, or indigenize it, or decolonize it, or whatever the term is that you're using. And it's the most pressing and most challenging. And certainly I've been in situations where I've been kind of tasked to do that alone and wasn't able to do it. But the more of us that we get together and we bring on more co-conspirators, I think we'll have a bigger chance. So all the health inequities that Indigenous people face, if you do a root cause analysis, you'll discover that it's because of colonialism, racism, lack of self-determination, which all, as you both know, is all about controlling Indigenous people for land. And so those same powers are at play in Indigenous health research as well. And so that's a challenge when you take like this colonial research system and try to employ Indigenous leadership in research. That's really challenging, for one. And then layer on that, especially in health research, and then layer on that, trying to like incorporate Indigenous research methodologies. That's really tough. And it's tough for me too, because I was trained in this system. And so having to constantly remind myself and challenge myself am I being true to myself and my people, and is there another way of looking at this problem from an Indigenous perspective? And most of the times, what I've discovered is that including both perspectives in a single problem may sometimes yield the best solution, but I don't know. What do you think?
I would agree.
What's the most pressing issue today?
So I agree. I think the challenge is that if you look at the health disparities that exist between Indigenous people and non-Indigenous people in what we now call Canada, they can all be traced back to colonialism. So the Indian Act, the reserve system, the residential school system, the Indian hospital system, and forced and coerced sterilization of Indigenous people with uteri are all some of the legacies that trickle down from colonialism. And in fact, only 2 of those are no longer in play, which actually tells us that like colonization is actually like still happening today. And so of course there are all these health disparities, and that leads us to all of these social determinants of health that like inherently plague most of our communities. How can you be healthy and well if you don't have access to stable housing and clean drinking water, and if schools on First Nations are funded at 70% of schools outside of First Nations? It's essentially impossible. And I would echo what Sarah has said about the research system, which is that you can't. I think a big challenge in Indigenous moving research forward in Indigenous communities is trying to impose a colonial research structure on Indigenous communities, and just the fact that typically large research teams from colonial institutions really don't have a great concept about the need to work with communities, right? Nothing about us without us. And they struggle to engage to bring Indigenous folks in to start co-developing like research questions as opposed to imposing research studies on Indigenous communities.
Yeah, I agree with both, especially the self-determination aspect. Again, I've lived my own life in a way that I've had to live. I've been a product of the reserve school system, federal and provincial. I fully believe in self-determination needs to begin with education, and I think the Waha Project is a great start to try to attempt at that self-determination of how we are learning the ways of becoming a doctor without the influence of institutionalized and colonial methodologies in that regard. I know our counterparts in Eastern James Bay and the Quebec side, they've started this where they're creating courses all in Cree language, and that's what I've often wondered is how effective, as a James Bay Cree man, how effective would the healthcare be when we have doctors and nurses from our own community speaking our language, right? So for me, I find the notion of self-determination to be a solution, or not a solution, but an answer to a problem of many problems and many questions that have come up over the course of numerous years for our people. So when it comes to everything that trickles down even to my position, it has to be self-determined. I have to design the information the way our people will digest that information. Nowadays it's on Instagram Reels, whatever else it may be. I have to study and analyze. Okay, well, you know what, the 30-second, it's too long form, so I'm going to do 15-second kind of blurbs. I have to understand that, you know what, the average 17-year-old doesn't want to read a paragraph on a website, so I gotta maybe put a visual there with a little overview and a link and keep them in a loop within the web page itself, so they don't go off to the rabbit hole and lose themselves trying to find this information. So it's making sure that when they click outward link that they're ready to take that journey. So again, self-determination, even how we give the basic information of for opportunities that we have here at the university. We've never had control over our own health care, even though that's something that we signed a treaty over in James Bay, and I can't speak for the other numbered treaties and the other people within those numbered treaties, but we expected more than what is there, as Kingston and Moose Factory are the oldest inland English-speaking settlements in Ontario. So self-determination for us, we don't know what that is. And as my father my late father, Gilbert Cheechoo Sr. would say, we were very easy to assimilate with from the black robes and the missionaries there. And so self-determination is new, and it scares leadership and it scares people because they're so used to just saying, okay, we'll do that. And now we have these younger generations that are coming up and saying, no, we're not going to do that. I want this and I want that. And we also have chiefs and councils coming in saying, yes, you know what? Hey, why are we always saying yes? We can say no. We can ask questions. We can challenge this. And, you know, I hope with the Waha project, my hopes is that, you know, the chiefs and the councils and the community come to the table and say, this is how we want our healthcare to be, and this is how we want our children to be trained, because this is what we need, not the southern dream that has no idea what the northern reality is like.
It's always great to hang out with you two. And when I think about what we've discussed today, I know I'm going to be thinking about this for a few days, if not a few weeks, that the answers to our healthcare problems lie in ourselves. I think we know what needs to be done. I know we know it needs to be done. And so the challenge is to get more people alongside of us. And in the work that we do every day here in the Faculty of Health Sciences, to bring more Indigenous healthcare providers into our system, I think that will help us, you know, ensure that Indigenous people can self-determine what we need to be healthy and well.
Yeah, I agree. I think progress is slow, and I think change is slow, and I think we're seeing things within our faculty move in the right way. I think having very visible and very strong Indigenous leadership is essential. I think having a voice within the broader leadership is really important, and is a great step moving in the direction we need to improve Indigenous health. And I think we're starting to see other types of institutions take notice, and I think working together is the only way we're going to get it done.
I think in the broader respects, when I first started at the university, I think the new recipe that was coming to the kitchen scared people, and that was okay. Like with leadership, with fellow colleagues, it's that you don't need to understand what the recipe is. You just got to know it's going to be a good meal at the end of it, right? And it's going to cook, and you're going to see things that even predecessors couldn't achieve, because at that time it was, what's our identity here at the university? And I feel like it's even though it's been there, I don't think it's been fully uncovered to its potential that it can be. And now that more people are trusting the recipe and waiting to see, it's starting to loosen a little bit in terms of micromanagement, these types of little things that can actually hold up in a big way a lot of the growth and progress that we need to make. And pace is such a big thing, and I feel like the pace is starting to speed up a bit more, which is really good for momentum and striking while the iron's hot.